Well, good morning, everyone, and Happy New Year. I hope you all are doing well in 2025, and it is so good to be back with you guys today. And we have some wonderful information for you about prescribing and pharmacology. So, before we get started, I am still practicing using Slido. And this is only my second time doing it. I had a good time doing it the first time, and I think you guys did too. And I want you all to join my Slido today, and I've put the little QR link up for you. And I would like for you to tell me where you're joining from. So I want to welcome everyone. If you're just now joining, use that QR link and put in where you're joining from today, and maybe y'all have snow on the ground like we do. And maybe you're somewhere where it's nice and warm. So take a minute and just for some fun, put in, oh, somebody's in Florida. I'm jealous. I'm jealous. So put in where you're joining from and put in what you could even put in what the weather is if you want to. I don't care. So just again, just to practice. And we're going to be doing some practice questions here a little later in our time together. So I want you all to just kind of practice doing this. Okay. Rachel's here for chat. So thank you, Rachel, today. I'll go ahead and tell you that. I appreciate you doing chat for us. And if there's any questions that you guys have, Rachel's always right there, ready to answer for you guys. So always good to have her here. Okay. Oh, okay. So cloudy, Mississippi is cold and windy. All right. So kind of my neighbors there, Mississippi and Florida. All right, so let's go ahead and get started. We have a lot of good stuff to do today, and we'll look at this Slido here a little while. I also need to figure out how to get your all's timer off so that y'all can see. So let's remove that. Okay, there we go. So let's go ahead and take a look here. If we haven't met, my name is Brittany. I'm a family nurse practitioner, and I work here at Archer Review. And basically, today I want to talk to you guys about some just literal prescribing pearls that I have learned from my own practice. And also, a lot of the meds that we're going to discuss here today came from the website Top like 200 or Top 100 Drugs. And I would really encourage you to look over that and be familiar with a lot of those medications because as you're seeing these patients out in clinical practice, it's important to like know your interactions, run your medications through like an interaction checker, things like that. And if you're familiar with some of these top drugs, that's just going to save you time. And so, today I really want to focus on this topic and I really want this to be interactive. And of course, focusing on the patient education aspects of this. And remember, my little disclaimer here is also this is for informational purposes only, and you are going to want to treat off of guidelines. Everybody who gets a medication should be tailored to their care, and you need to look this information up for yourself and for your patient. So don't take anything I say in this website as true gospel. Look it up for yourself. So, for example, metformin, I'm going to say is a first line drug for type 2 diabetes. But if your patient has, chronic kidney disease and their GFR is not to the level where it's safe for them, obviously we're going to have to go to something else. So just an example there. And the other disclaimer I will say too is this is a medication webinar, but oftentimes our first line treatment, and ideally our first treatment is going to be something simple and it's going to be lifestyle changes. So before you ever initiate prescribing something for a patient, you need to pay attention and make sure that they have been equipped with the tools and the education and the encouragement to try to make lifestyle changes so that they can be on the least most effective dose if they are on medication, or maybe they end up not having to take the medication. That would be that most ideal situation, right? So just those are my little disclaimers there for you guys as we're going along through here. All right, let's talk about first these American Heart Association guidelines and hypertensive guidelines, right? So this is, they have kind of moved towards the American Heart Association. We also have the JNC8 that we can look at as well, but I'm going to go off of American Heart for blood pressure guidelines. And you guys pretty much know this, but pretty much now, they are calling stage one hypertension 130 to 139 over 80 to 90. And, when we start thinking about giving medications, we're going to start looking at that 140 over 90 range. So ideally, our patient has a normal blood pressure, which is now defined as 120 over 80 or less. So again, these blood pressure guidelines have gotten a lot tighter in recent years. This is something that if you've been a nurse for a long time, that I would familiarize myself with so that as I'm talking with patients, as I'm looking at guidelines, I'm aware of what the American Heart Association has to say about blood pressure. All right, let's go ahead and talk a little bit about antihypertensives. So, we have a lot of different drug classes, and our first gold standard is going to be our ACE and ARBs. So, our angiotensin converting enzyme inhibitors or our angiotensin receptor blockers. Now, remember, these patients cannot take these together, but ACE inhibitors are going to be involved in playing a critical role in the renin-angiotensin aldosterone system. And remember, this cascade is going to be the one that helps to control blood pressure and helps them to maintain fluid and electrolyte balance, right? So the primary role of this is going to be constricting those blood vessel. Excuse me. The primary role of angiotensin 2 is going to be constricting those blood vessels and increasing the blood pressure. And so this here is going to help them to actually decrease their blood pressure by focusing on that cascade. Okay, so also the other thing is we have some calcium channel blockers, we have beta blockers, which again are not going to be first line. And pay attention with your diabetic patients, because what can happen, y'all can pop that in the chats, what can happen with patients who have diabetes who are placed on beta blockers, and then also thiazide diuretics. So you can see the top two gold are at the top, and then you have these other classes that you can be used. And of course, beta blockers, the good news is they are used in pregnancy. Now, there is a little mnemonic that I want you guys to remember for patients who are pregnant and blood pressure medications that we can use for them. And that's going to be LMN. So think about the alphabet, LMN, and that's going to be labetalol, methyl-dopa, or nifedipine. So those are going to be safe in pregnancy. Now I'm going to open up the chat and see what y'all wrote. That's right, absolutely. So beta blockers can have an adverse effect on blood sugar with patients with diabetes. That's right. So that's why we're just, again, doesn't mean you can't prescribe them, just means that we need to pay attention and make sure that we're keeping a good watch over their blood sugars. All right, let's go ahead here and move on to the USPSTF and what they talk about with, again, cardiovascular disease and mainly the cholesterol guidelines. Okay, so lipid screening. So first of all, we have patients, we are screening throughout the lifespan now, because as we have learned, patients can get set up for heart disease at a young age. And we're really trying to mitigate that because there's genetic links to this, we're finding out. And so we're going to be screening these patients starting around 9 to 11 years old, and then again at 17 to 21. And then, of course, men starting at age 35 or younger with a risk of cardiovascular disease, we're going to start that screening. Women ages 45 or those at risk also may start sooner. And if they're low risk, then you're going to do it every 5 years. There is a prevention calculator. We will put it in the chats for you. It's often used like an ND-Calc or prevention risk calculator through the American Heart Association. And this is going to give you a percentage. It's going to be putting in things like, what is the patient's blood pressure? What is the patient's age? And again, this is for patients that are 40 to 75 years old that we're using this for. But it's going to kind of give you the risks and the benefits of these patients with whether or not to start statins. So you can see over here on the right-hand side of my screen, I've put talking about these ACSVD risk calculators, if they're low, borderline, or intermediate or high risk. And so when do we want to start thinking about initiating statin therapy in ages 40 to 75? Can you guys tell me that? I'll put that, y'all can put that in the chats. Who can put that in the chats? What percentage do we start considering statin therapy? And again, if these patients, you're screening younger patients, they have a history or whatever, you might consider doing like an apolipoprotein A or B to check for that genetic link. Some of these patients may even be managed at the lipid clinic if they're really young. And of course, let's go back and look at the chats here. All right, yep, that's right. So in that 5.5 to 7.5 risk calculation here, when they're starting to get up to that intermediate risk, especially, you're going to consider starting statin therapy, okay? And remember, for statins, we have the different intensities, right? So we have high, moderate, and low intensities. Now, the good news for statins, even though they're really common medications, these meds there's only like 8 of them right now on the market. And there's other things that we can use for lipid lowering agents, but by far statin is going to be your first line. And the good news is that if you know those, 8 or 9 meds that are on the market, you pretty much know your whole drug class for statins, because you can see here, they will just titrate up, and that is what is going to make their intensity. So for example, I can have pravastatin 10 to 20, that'll be low intensity, and then moderate intensity, I can just move it right up to 40 to 80 a day. You can see here, I've got Lipitor at a moderate intensity, 10 to 20 milligrams a day. I move that up, and it becomes a high intensity. We only have 2 high intensity statins here listed. And I want you guys to tell me in the chats why you would start someone on a high intensity statin. So regardless of their ACSVD risk calculation, why would you start someone on a high intensity statin? So can you guys tell me in the chats? All right, I'll give you just a minute to think about that. Absolutely, that's right. So if they've had some sort of cardiovascular event, then they're going to be automatically placed on a high intensity statin, right? Okay, let's go ahead and look at some statin side effects. So these here are rare, but it's something that we have to be aware of if we're prescribing statin therapy. So first of all, rhabdomyolysis, that one is going to be that muscle pain, that dark urine. You're going to send these patients to the emergency room for a little bit more workup, because this is kind of an emergency, because as you can see here over my picture, I've got it listed for you as muscle breakdown. So this is something that, again, is rare, but if your patient is complaining of severe muscle pain, and I'm not talking about a little ache, I'm talking severe muscle pain and or dark urine, these patients need to go on to the emergency room. Drug-induced hepatitis is another, again, rare but serious side effect. These patients are going to have their ALT really skyrocket, that liver enzyme to increase. They may have jaundice, they may have abdominal pain, and you're going to get a CMP. And I will just go ahead and draw to your attention right here, order a CMP. So anytime I start a medication, when it's something like a blood pressure medication or a statin or something like that, I will go ahead and order a CMP. And why do I do that? It's because I'm looking at their liver and their kidneys function and making sure that everything is humming along and staying good. So I'm going to get a baseline, and then about 4 to 6 weeks after starting the medication, I'm going to order another comprehensive metabolic panel and make sure that their liver and kidneys are still doing well, and checking and making sure that this drug is not adversely affecting their levels, like their liver enzymes or something like that. So that is just good practice for us to order that extra lab and double check. And I'll often bring them in, make sure that they're doing okay, make sure that they're not having any side effects, and make sure that we feel like they're on a good dose of medication. And so that is just, something that I have kind of added to my practice. Something you might want to consider adding to yours if you're not already doing so, is kind of just do a little medication check-in after you've started something, in 4 to 6 weeks. Now, something like a depression medication, you might do it as little as 2. So just depending on what you're given. But for the blood pressure and the statins, and even the diabetes medications, I'll bring them in about a month later and check in on them. All right, let's go ahead and take a look at our next thing is hemoglobin A1C. So this one here comes from the American Diabetes Association. You can see here normal is less than 5.7%, Pre-diabetes will be 5.7 to 6.4%, and diabetes is going to be 6.5% on two readings. And so this is something where if these patients are starting to kind of hang around in this pre-diabetes range, or maybe they're normal and they're kind of sitting right there on the fence at like 5.6, something like that, I really want to have a conversation with them, really want to start talking with them about prevention, talking about decreasing carbohydrates, decreasing sugars. Are you walking? Are you exercising? Decreasing your alcohol consumption, because I really want to bring that patient back to the side of normal and out of that creeping towards prediabetes, which it could lead to full-blown diabetes, a few years later. And so we're already sitting down, having these conversations, hopefully before they ever get to diabetes. Now, if they are kind of in that pre-diabetes range, maybe they're 5.8, and then 3 to 6 months later, even if, maybe they haven't been real great at keeping compliant with their lifestyle changes, and now they're 6.3, something like that, you can consider giving a little bit of metformin at that time if, you feel like that's indicated. So again, the word I want you to remember when you're checking labs is the word trends. I'll kind of trend things for a little while and take a look and see kind of where things are going. So ideally they're going down though. Okay, so let's talk about metformin. Okay, like I told you at the beginning here, this is the one of the first lines for type 2 diabetes. And this is metformin, often marketed as glucophage. This one basically is going to be your first line unless their GFR is like or 30. If they have a lot of kidney issues, then I would not start with this one. But some of the side effects for this is GI symptoms. And one of the things that you can do is order the extended release for this. Oftentimes, we'll start patients on an initial dose of 500 milligrams per day, whether that's the extended or just the regular release. And they will take that with their largest meal. And then we'll gradually increase it in a few weeks while after their system has kind of gotten used to it. So that's one little thing that you can do. How it helps is just kind of decreases the absorption of glucose from the intestines and it increases the uptake of glucose in the peripheral tissue. So you kind of want to move it where it needs to go. And again, some contraindications here, paying attention to renal impairment. Elderly patients, again, you need to pay attention, make sure that they can tolerate this. And if they're, have some sort of hypoxic state going on, then you would want to also consider something else. All right, GLP-1, these are really common right now. If you remember that little acronym MET12, that will serve you well. Now, what does that mean? If you're thinking about main guidelines for diabetes type 2, you can think about MET12. Metformin is first, and then they can go to either an add-on of a GLP-1 or an SGLT2. So if you say MET12, that will help you to kind of remember that in your mind. And a GLP-1, these are very popular right now. So you all have heard of Ozempic or Mounjaro, Wegovy. These got really popular with knowing the side effect of weight loss, and that is what made these really popular, but they actually are good drugs. These medications are injectables, usually once weekly, and they work basically by slowing down the gastric system, the GI system. And so one of the things is with this one is that they do have a black box warning for slowing down the GI tract. They have a something that can cause bowel obstruction on there. So again, if I'm going to prescribe this, I always start this really low and go slow. I talk to my patients about history in their family of things like thyroid cancers, pancreatitis, gastroparesis. If they have personal histories of those things, I'm really, really careful. Probably going to consider something else instead. And again, GI symptoms abound with this, with how it works to slow the gastric emptying. And then, of course, it can lead to pancreatitis. So this is something that you really want to pay attention to if you're prescribing these medications. And again, start low, 0.25 milligrams, see them back in a month, 0.5 milligrams, see them back in a month. And you want to start really low and go slow with this because they do have those black box warnings. All right, let's take a look here at our next one, MET1/2 SGLT2 inhibitors. These also are really popular as well on the market. So that's where you'll have like your Farxiga, your Jardiance. There is also, we are seeing this with cardiac patients sometimes are taking these SGLT2s, even if they're not diabetic. And you can see that this is basically going to work thinking about decreasing the absorption of glucose and a renal threshold for glucose. So this one, you really need to pay attention for this one with especially your older people, because this one can cause things like yeast infections, UTIs, because how these are working is the glucose is going to be basically urinated out. So if you do a UA on these patients, a lot of times you'll see a whole lot of glucose in their urinalysis, and that is the mechanism of action for these drugs. But again, something to pay attention to is if your patient has a lot of UTIs or yeast infections, this may not be the best one for them. If they get dehydrated easily, maybe they're an elderly person, or maybe they are on cardiac medications that can cause hyperkalemia. You want to really pay attention because this one can kind of dehydrate patients quicker and cause these unwanted side effects. So again, start low and go slow on these. All right, let's talk about medications for hypothyroidism. So the first one we're all thinking about is levothyroxine, correct? And that is going to be our first line treatment for hypothyroidism, most likely. We can have primary and secondary hypothyroidism. So when you think about primary, it's going to be something like, Hashimoto, something like that. Secondary may be like due to a tumor. So again, just making sure that we're getting the correct diagnosis there. Oftentimes, symptoms here will be things like fatigue or brain fog, constipation, dry skin. Things are slowing down, right? Weight gain, more depressed, sensitive to cold, slower growth. So when you think about hypo, you can think about low, you can think about slow, and that will give you some of your symptoms if you're trying to pick that out on an exam. Now, first of all, we're going to talk about how do we diagnose hypothyroidism. So you guys, can y'all put in the chats what you would want to draw on your labs to check if a patient has hypothyroidism? What do y'all have? What are y'all putting in your chats? I'll open up the chats. All right, so I have it right here if you need a little hint. TSH. T3, T4, right? So, looking at that, if you feel like you're trying to rule out something like Hashimoto's, you can do the TPO, checking for the antibodies. And then, of course, subclinical, you can have that. Oftentimes, these patients won't actually have symptoms. Sometimes you'll just kind of catch it. On a screening, but oftentimes their TSH will be elevated, but their T3, T4 will be normal. So, again, just thinking about TSH, T3, and T4 go together on hypothyroidism. All right, so of course, Synthroid, your initial dosing is going to be age and weight based, and you're going to adjust this every 4 to 8 weeks. Now, remember that TSH and that T4 have an inverse relationship, and so think about when the TSH is going up. I know it sounds crazy. The TSH is going up, you're going to increase your medication. So counsel your patient on the use of medication as well. So take 30 to 60 minutes prior to breakfast or 3 or 4 hours after dinner. This is one where we want to make sure that we're not putting it with food. And then also avoiding things like iron, calcium, PPIs, because again, this can inhibit absorption. And a pregnant patient or lactating patient may also have a higher dose adjustment requirement. So oftentimes we'll kind of co-manage these pregnant patients with either OB or endocrinology if they have had hypothyroidism pre-pregnancy in the past. So just something to kind of pay attention to there. Their dosage may change. All right, let's talk about asthma. This is an obstructive pulmonary disease that begins with a trigger, such as an allergen, virus, or even exercise that causes airway inflammation. It leads to increasing mucus production, swelling of the bronchial tissues, and muscle constriction. So what are we going to do about that? First, we're going to test and diagnose with spirometry, right? That's going to be our first line screening for that in adults. Kids might do well with having like a little trial of albuterol albuterol, seeing if that's helpful. But spirometry is technically the gold standard. And again, we're looking for that FEV ratio, FEV1 of 80%. And that will help us to determine whether or not our patient might have asthma. Now, how do we talk about what we want to give medication wise for our patients with asthma? Is we're going to use the GINA guidelines. And those guidelines, I'm put up the ones for adults and adolescents 12 and over. There is separate guidelines for younger children, but this is one where I just kind of wanted to talk to you about that you might see on your boards. And first of all, you can have different tracks, but first of all, the inhaled corticosteroid has become in the last maybe 5 years or so the number one treatment choice. You can use that as needed, PRN, or you can use it kind of like as a rescue inhaler. And really, you don't want these patients to become to where albuterol is just, they're taking it all the time, and it becomes a little bit less effective. If that patient's in the back of an ambulance or in an emergency room with an asthma attack, we want to give them albuterol. We want it to be super effective for them. And so that is why some of these guidelines have changed. So inhaled corticosteroids usually will be your first go-to for these patients. If they're already on a short-acting broncho, right here, you can do out that AKA albuterol, you can add an ICS in and it can be taken at the same time. So just something here that you can think about. That you can do with these patients in addition to the albuterol. And as you go down, you can see right here, they can get an asthma control score, and that is just a questionnaire. It asks things like, well, how often are you having nighttime symptoms? Or, are you able to do your activities of daily living without shortness of breath? It'll ask questions like that. I think it's a score of 19 or less. They may not be super well controlled, and you may have to kind of do a reevaluation of their medications, because we always want these patients on the least most effective dose for all meds, but especially for our asthma meds. All right. Also, a new thing that you might see, just to update you for asthma, if you've been practicing for a little while, or you've been a nurse for a little while, is smart therapy. And that is essentially, like I just mentioned before, using the same inhaler for rescue and maintenance. So, again, smart therapy, they only have to have one inhaler at home, one inhaler in their purse, whatever it be, and they're not having to switch back and forth between a rescue inhaler and the inhaled corticosteroid. And so that is another rationale for kind of why do we change the guidelines, and inhaled corticosteroids can be used for both, as you can see again back there where I showed you. All right, so let's just take a little breath here. We're kind of halfway through our time together. I'm getting ready to ask y'all some questions here in just a few minutes. I have a few more medications to talk to you guys about, but in the meantime, let's talk about the Archer Review nurse practitioner information and some of the packages that Archer offers. So, of course, we have these free webinars. We have been meeting on Mondays for a while now, and then we also have several other instructors that are meeting several other days and evenings of the week. And, we want to offer these free webinars to you guys. But in addition to that, we also have a free question bank for 7 days. If you're getting ready to take a test coming up, I would encourage you to sign up for the Q Bank and look at over 1,600 questions. They all have a rationale. There's a test readiness predictor, and this is something that you can use and really put to the test there. Also, we have another option here is on demand, and it's 16 and over 16 hours of content. There's bite-sized videos. So if you just want to talk about asthma, you can go right there in the directory and just talk about asthma. Furthermore, if you want to just talk about, inhaled corticosteroids, there's a little blip that will talk to you just about that. So you can go and you can make sure and focus on just the topics that you are interested in, bite-sized videos on the go on your phone, and in-depth topic coverage. So you can go as little or as much as you want. And then the one that we're really recommending for everyone is kind of putting these two together plus some extra bonus things. The SurePass Pro. bank you're going to have on demand. But in addition to that, you're going to have access to a 3-day live review. We have one coming up next month, so stay tuned for that. Also, mentoring. We have mentoring all of the instructors here. We will talk to you. We will sit down with you. We will tutor you. We will look over whatever you want us to look over with you and go over whatever it is that you feel like is your biggest struggle. And pretty much there is a passing guarantee for this, and you can use this resource in a variety of ways. So again, I would encourage you to scan the QR link and take a look at the SurePass Pro. And I will say this, regardless of if you bought anything today or where you're at in your journey, we just want to connect with you guys. And that's why I love Archer so much, is because they really do care about their students. They want, we all want to see you perform well on your tests and in your schooling and even as a nurse practitioner beyond. And we really want to connect with you. We have very active social media groups, whatever you are using, whether it's TikTok, Facebook, Instagram, whatever it be. We have a great community here that's really supportive, and encourage you to connect with us there. That's how you can sign up for more of these free webinars like we're doing today. That's how you can get information. We do giveaways, so lots of good stuff. Also, if you have questions or just aren't sure exactly which package would work best for you, you can email the nurse practitioner at archerreview.com. And I know that Rachel looks through those and she'll answer whatever questions you have. So again, take a minute here, scan, and just look at all the exciting things that we have to offer. All right, let's go ahead. We're going to just keep moving through, and then we're going to go through some practice questions together. So, of course, depression. First of all, we have our screening, which is going to be our PHQ-9, which is most common. We're going to really want to take a good, thorough history. We never want to put somebody on depression medication if they have some other underlying thing. So, ruling out lab works like thyroid imbalances, how we talked about patients can be definitely more slow moving with hypothyroidism, vitamin deficiencies, maybe their B12 or D is low. Rule out organic causes. Maybe they're just going through a really hard time and they don't need depression medication. They need to see a counselor. So again, really doing a thorough workup, spending that time with your patients before we just decide to do medications. If you've decided that medication is the next best step for your patient, we have lots of different things that these patients can, to choose from. SSRIs, I would say, being one of the most common drug classes, and we're going to get through those here in a minute. Some of the non-pharmacological ways that we manage depression, again, we as nurse practitioners, we really want to be health promoting. We really want to look at patients holistically, right? And so I think everyone who is on treatment for depression should probably be seeing a counselor, should be having some sort of therapy where they can go and, we can provide a counselor list for our patients and just having that support for them as well. Also, lifestyle modifications. Are they sleeping? Are they eating? Are they eating too much or too little? Are they having exercise and movement in their life? How about their stress levels? Are they reducing those? So again, depression, I always talk about as multifaceted, multi-pronged approach. And this is one where if you do decide you want to do medication, this one is going to be one that we're definitely monitoring closely. And then anxiety, the same kind of thing. Oftentimes we can use SSRIs for anxiety as well. We want to have those open-ended questions for our patients. We want to offer them a safe space to talk. And then, of course, investigate for any physical symptoms. We can administer the GAD-7 and, of course, getting those labs. Again, before we do any medications, we are going to want to order labs and do a thorough history and physical before we start, doing SSRIs and things. All right, let's talk about those SSRIs, selective serotonin reuptake inhibitors, right? So these block and inhibit reuptake of serotonin, and it keeps that serotonin available in the brain. So it will help to improve mood and alleviate symptoms of depression and anxiety over time. These still have a black box warning for increased suicidal ideation. So again, this is one that you're really going to want to pay attention to and check on your patients. It takes about 4 to 6 weeks to reach effectiveness, and if you you start the medication today, it's going to be about 1 to 2 weeks, probably about, even maybe up to 4 weeks before they're really feeling much of a difference. And so that's again why we're going to want to have this close follow-up, because they don't just take this pill and it's an Advil in 30 minutes, they feel better. This one takes a long time to kind of build up in their system and get them to a good therapeutic level. Also, side effects common are things like weight gain, decreased libido, and GI upset. We already talked about the black box warning. Here's a list of them for you here on the right side. And these right here, a contraindication would be serotonin syndrome. So taking multiple SSRIs is not generally recommended unless they're like under the care of psych, or if they're taking like an MAOI, then also probably not the best thing to do is start an SSRI. So again, if patients are starting to get on multiple mental health medications, it might be time for a psych referral, so that they can be monitored in an appropriate way. All right, serotonin syndrome. This is an emergency. First of all, excess serotonin builds up. We often will see the use of multiple things together. So things like St. John's wort, migraine treatments, antidepressants, especially multiple SSRIs combined together. Oftentimes, these patients will have some sort of a rapid change. They'll be confused, they'll be tachycardic, very agitated, muscle twitching, sweating. So again, these are very concerning symptoms. These patients are going to be treated in the emergency room and obviously going to probably be discontinued off of their medication until they can get to a stabilized level. All right, let's talk about gastric esophageal reflux disease. So let's talk about some of these first line treatments here. First of all, there's no typical physical findings with this. Patients might complain of heartburn or some indigestion, burning in the chest, nausea, vomiting, bloat. Are the symptoms worse when lying down? Is a question we can ask. Are they eating a lot of spicy or acidic foods? If they're having tacos and washing that down with orange juice, even if they don't have GERD, they're probably going to have GERD. So really talking to them about lifestyle changes. Some of your red flag symptoms, difficult or painful swallowing, or they like eat and it feels better. They are going to probably need an endoscopy. And so you would definitely refer them out to GI for that. Anyone who has been on PPI therapy for like 12 weeks, and they can't really wean down, that also may be warranting a talk with GI. This is some options we can do. So for GERD, our first line again is going to be lifestyle, just like y'all see for most of the things here. Losing weight, taking some pressure off the abdominal wall, smoking cessation, avoiding those trigger foods, eating at least 3 hours before bed. Might start with an H2 blocker. Thinks about like famotidine, Pepcid. It's going to be a really close first line that we give. And this is going to be blocking that histamine receptors in the stomach and reducing the acid. And these do work fairly quickly. And then these patients might need to have something that, at least for short term, is a PPI. That's going to be your goldest standard. If I imagine a ladder and at the very top, I think about something like a Protonix sitting there, the PPI. And these are going to basically just be reducing the acid production and promotes healing of the esophagus. If they've had long-term chronic GERD, chronic indigestion, this might be warranted for them. And again, they take longer to work. And usually we can use these 6 to 12 weeks in primary care, try to start backing them down on some of this stuff. And if that's not working, may consider it a GI referral. All right, let's talk about estrogens, hormone replacement therapy, of course, contraception, lots of different things that we can be using estrogen for. Um, Also, little benefit for osteoporosis, but have to think about risk versus benefits, but they're not recommended solely for prevention of osteoporosis. That's my note there. If it's more of just like vaginal dryness, we can use like topical estrogen. And I want you guys to put in the chats why you would not give unchallenged estrogen, i.e., not with progesterone, to someone with an intact uterus. You guys need to know this for your boards and for upcoming tests, but most importantly for clinical practice. I want you guys to put in the chats why you would not give estrogen, topical. I'm sorry, not topical, systemic estrogen without progesterone in someone who has an intact uterus. All right. This does not carry the same risk. These topicals don't. So we can give things like estradiol. They can be used for longer term without that risk. And then, of course, also dyspareunia, which is just painful intercourse due to atrophy of the vaginal tissue. Again, these can kind of go together and hold hands. We can also use some topical estrogens for that. All right, I'm going to open up the chat, you guys. Why do we not give unchallenged estrogen? Is because it increases the risk of things like endometrial cancers. So we always want to give it with progesterone to someone with an intact uterus. Again, that's systemic estrogen. That's why you'll see combo birth control pills, estrogen and progesterone together, or you'll see progesterone only, but you're not just going to see estrogen only unless it's like for hormone replacement therapy, which again, for menopausal symptoms, and it's not going to be unchallenged. And then you can use topicals by themselves. All right, let's talk about the adverse effects of estrogens. We just talked about this a little bit. Cancer risks, increased endometrial cancer, especially with unopposed estrogen. It's reduced with combination. Cervical cancer, don't always have a great link there, but we know the endometrial cancer. Ovarian cancer helps often is decreased with combined oral contraceptives, and then breast cancer has mixed results. So again, we know the endometrial cancer, and that's enough to kind of shy us away from unopposed estrogen in patients with an intact uterus. All right, let's talk about some of your antibiotics, and then we're going to get to our quiz here in a minute. So, mechanism of action for penicillins is going to be inhibiting the wall synthesis of gram-positive cocci. These are broad-spectrum antibiotics commonly used for syphilis. That's going to be your penicillin G. And then the other ones, you can use things like respiratory infections, skin, UTIs, and that's going to be more of your amoxicillin, your PenBK, because again, the penicillin G is mainly for syphilis. And then also we have these combo ones, amoxicillin with the cluvenate, also known as augmentin, and those are the stronger antibiotics. Let's talk about sulfa drugs. These inhibit bacterial enzyme activities. These are often combined medications. We can use these with UTIs, acne, skin infections, not generally given for pregnancy because they do carry a little risk of Stevens-Johnson syndrome. And Bactrim is our most common one for the sulfa drugs. All right, our tetracyclines, often N-cyclin. These destroy the membrane of the bacteria and inhibit the replication of them. And oftentimes these are great used for MRSA, Lyme disease, Rocky Mountain spotted fever, kidney infections, acne. And I have right here, not generally used in pregnancy. However, there is a little outlier to that. Can you guys put in the chats what the outlier would be for that? Also, teeth staining in children less than 8 years old. So the guidelines are kind of changing on that a little bit. Used to be we didn't give it at all for Lyme's. Now you might still consider it. I've got some examples here for you, but let's open up the chat and see for a child or for a pregnant person. Usually, if they have Rocky Mountain spotted fever, absolutely great job, you will go ahead and give the tetracycline medication for those. Cephalosporins, we have lots of different generations. I have them listed here for y'all on the far right. Common uses, these are great for skin and bone infections, respiratory infections, some of your STIs, meningitis, MRSA. These also will work for some gram-positive and some gram-negative bacterias. So they're a good broad spectrum because they cover lots of different things, and they're safe for pregnancy. So again, these are a good go-to for a lot of different things. And you can see here I have better positive and better negative gram coverage depending on which generation you're in. So if you're not sure, you can always take a wound culture or whatever if you're not sure, and kind of start them on something and then change it up if needed. All right, let's take a look here at macrolides. These inhibit bacterial protein synthesis. They're a great alternative to things like penicillins, people with allergies. Caution with blood thinners, especially things like warfarin. These are great for upper respiratory infections, soft tissue infections, and they are pregnancy safe as well. I have some listed here for you, things like the Z-Pak, erythromycin, that's going to be on that list. Fluoroquinolones. These are one that we want to be very careful with. These inhibit nucleic acid synthesis, great for respiratory and urinary tract infections. However, these do carry a warning with them, and this is what we want to talk about when we talk about antibiotic stewardship. Of course, not giving antibiotics out just willy-nilly, making sure that we've assessed the patient correctly and they actually have an infection and we're not just treating a virus with an antibiotic. But fluoroquinolones is going to be reserved for more of those severe cases. Of course, things like Cipro, think about complicated UTIs, things like pneumonia in a hospitalized patient or someone who has a lot of comorbidities. So again, this is not going to be our first line go-to, but they're a great drug class and they are effective in the right setting. I've got here a little antibiotic person for you. Basically, I've put kind of some of the things that you would give antibiotics for just to kind of sum this up. You all can look at this. And I'm not going to read it to you, but you can see all the different antibiotics and what you might consider what for. Good rules of thumb when prescribing. This is just, my cheat sheet of what I have thought about and talked about with patients and other providers. So first of all, before you prescribe, you want to know your patient and their labs. How I said at the beginning of this webinar, everybody needs individualized tailored care, and you need to make sure that you're aware of their comorbidities, what medications they're on, and then also their lab values. Things like creatinine clearance, you can use a calculator for to determine that. Elderly patients are unique. So think about polypharmacy. I don't want to give a medication to combat the side effect of another medication if I can get around it, right? Beers criteria. That's going to be that 65 and older paper that's been written for drugs that we need to use caution with in the elderly. So if you're not familiar with that document, become familiar with it. Also thinking about barriers to care. If I give some fancy brand name drug, then that may not be affordable for most of my patients. Also, compliance. Are they having memory issues? Are they, not able to go get their medication? Do they have financial barriers? Whatever it be. So think about their barriers to care. And then also you want to think about risk versus benefits. You want to consider and discuss that. You always want your risks to be less than your benefits before prescribing a medication, right? So I always think about that. And then allergies and pregnancy status. This is going to be important. Did you ask these things before you prescribed it? And it might not always match the chart. So I make sure what's coming out of their mouth is documented on the chart and making sure that everything is lined up. Now, this little picture right here came from actually the asthma guidelines, okay? And I've changed it up though to go for us. You want to assess the situation. You want to titrate the medication to make sure that you're matching all of this. And then you're going to prescribe the medication. You're going to bring them back in to assess it. Are they on the effective dose? Are they on a good amount? Are they on too much or too little? And then you're going to give them that refill. And then you're going to just continue this cycle as long as they're on that medication. So this is just something that, again, I just kind of compiled it all together. This is something that, again, you can consider when you are prescribing. All right, it's time for our Q&A. I hope you all have joined us. If you haven't already, you can do so now for our Slido. And basically, like I said, this is my second time using this. So I want to give you all just a couple of practice questions before we get started on the real ones. So first of all, what level of nursing education are you working on right now? So associates, bachelor's, master's, or doctorate. So this just kind of gives us an idea of kind of where you're at. Okay, great job. Y'all are working on your master's. Very good. So, and the thing I like about this too is this is anonymous. You can put it in the chats. as well if you can't get the Slido link to work or whatever. So that's fine, but this one is anonymous. So also, how comfortable are you with prescribing medication? If you're in a master's program and it's like family nurse practitioner or CRNA, something like that, you will most likely be prescribing meds. So how are you feeling about it? You're feeling nervous. Yeah, absolutely. And I'll tell you this, you are going to be nervous. If you weren't nervous, I would be worried about you because we want to make sure we're doing the best for our patients, right? And so you want to be, feeling not so nervous that you're paralyzed, but you want to be feeling like, hey, I need to be checking everything. I need to be looking over everything. So I'm okay with that, especially if you're just getting kind of started into practice or you're still in school. That's okay. That will come. And you will learn every medication you go out the door, send out the door, you'll learn something about, something you'll think about something that you hadn't thought about before because you're going to tailor it to your patients, right? All right. So y'all can join the quiz. I've got right here on the quiz, and I will just say I'm going to toggle back and forth between the screens here. Um, and basically, I just want you to see how I have it listed here, A, B, C, and D. So it's just going to say practice question one, A, B, C, and D. So you guys can vote on the phone, and I'm going to go back to my slideshow, if you will, and give y'all the question. All right. So Miss Hester, 82 years old, was seen in the ER last week with cellulitis on her right lower extremity and was placed on clindamycin and told to follow up. She states she's taken the antibiotic exactly as prescribed, but it's not improved. And she wonders if she needs more antibiotics. Which agent would be best to proceed with? So thinking about our antibiotics that we just talked about. So vancomycin, amoxicillin, doxycycline, or cefepime. So which one do you all feel like this one here is just not getting better? Are we going to increase? Are we going to keep the same? Are we going to, um, you know, what are we going to do? Are we going to change it altogether? What are we going to do with this patient? So let's pay attention and see what we're going to pick. All right, let's go back over here. What you thinking? So practice question one. All right. Oh, you know what? Again, I told y'all this was my second time, so thank y'all for having good patience with me. I think y'all ran out of time and before I gave you the question. So we're going to reverse that. Okay. Practice question two is going to be set up exactly the same. So y'all can put it in the chats. I'll open up the chats just like we used to do. And tell me what y'all are thinking for the answer to this one. So let me take a look. I'll open it up. If y'all want to put it in here, what you thinking it is, I'm going to give you the answer here just in a minute. What do y'all want to do for this patient? Y'all can put it in the chats. All right. So if you picked vancomycin, you would be correct. Very good. So, not getting better with the clindamycin, so we're going to go ahead and give her bank. All right, let's go ahead and look at this one, and then I'll open back up the Slido for y'all. Miss Deals comes to your primary care clinic complaining of urinary frequency and dysuria for 3 days. She is afebrile. She denies flank pain and states that she found out that she's pregnant 2 weeks ago and is going to see her OB next week. Her urine dipstick was positive for nitrites, and the nurse practitioner decides to treat her for a urinary tract infection while awaiting the culture. And the nurse practitioner chooses which of the following to treat the suspected UTI. So again, we've done the UA. We've talked about risk versus benefits. If this is a pregnant patient, we don't want her having to wait for 3 more days. So we're probably going to go ahead and start something. We want to do something that's going to be safe for pregnancy. So y'all can pop it in the chats, or I'm going to go back to the Slido. Amoxicillin, macrobid, Cipro, or Rocephin. Okay, so I'll let y'all look and get your answer, and then y'all can pop it in right here. Okay. So let's go to practice question two. All right. So I think y'all got 20 seconds counting down on your clock, and y'all can put in what you think. What do we have? Like I said, y'all can pop it in the chats too. All right. What'd you guys put? Where'd that go? All right, the answer to that one was amoxicillin. Okay. I don't know where the information for that went. I'm sorry. Okay, let's practice this one. The nurse practitioner is prescribing medication for this patient. He's 77 years old with gastroesophageal reflux disease. Which of the following medications would be the best choice for the first line therapy? So again, thinking about our prescribing pearls today, we're sticking with first line therapy. Which one do you all think would be best for this patient? Is it going to be Pepto-Bismol? Is it going to be Tums? Is it going to be Pepcid? Or is it going to be Prevacid? Again, first line therapy should be lifestyle changes, right? So now we're moving on really to second line, which is going to be a medication. So y'all can pop your answer in the chat, or y'all can go to Slido. I will pull it back up for you. Oh, what happened here? All right, Slido. And y'all go ahead and put in what you thinking. Oh, okay. Practice question 3. Okay. So what do y'all want to put for this patient? What's he going to be taking? Y'all can go ahead and vote now. If you haven't joined us, you can join here on the QR code. Okay. All right. Okay. All right, and our answer for this one is going to be D, because proton pump inhibitors such as Prevacid are going to be the best choice for the short-term aggressive treatment for geriatric patients who have a high risk of complications from GERD. So high doses or long-term use can increase risk of things like fractures and malabsorption. So that's why we're going to try to do this for a short term and try to back him down. Okay, very good. All right. Which of the following medications for depression is contraindicated in a patient with comorbid epilepsy? So we didn't really talk about this too much, but we did talk about SSRIs a little bit. See if you guys remember this from maybe one of what your book said. So Lexapro, Wellbutrin, Zoloft, or Vibrid. And I'll pull up the Slido here just in a second and see what you got. All right, I'll let y'all vote on practice question number 4. All right, y'all did do practice 3. Very good. All right, practice 4. So here you go. 20 seconds on the clock. What are you all thinking for this patient would be contraindicated for epilepsy? Which depression medication? And we'll go ahead and look at the answer together. That is going to be answer B, Wellbutrin. Okay, so that one is an antidepressant. It's known to lower the seizure threshold. It's contraindicated with patients with seizures like epilepsy. Tricyclic antidepressants are also contraindicated with patients with epilepsy as well because it can lower seizure threshold, but that wasn't one of your options there, right? So again, you can see here how the boards are not going to confuse you. Usually, they're going to give you one solid answer and go through. So again, even if you didn't know the answer to that, you can take that test taking strategy tip and apply that for other questions. All right, so this is wrapping up today. I thank you all so much for joining me. It was a great day to kind of get back in the swing of things. I'm going to be back with y'all very soon, and we're going to have other webinars coming up this month. I hope you will definitely get on and look through and see what is most helpful to you. Also, just before we close here, I'll stay around for just one more second. Rachel's here still. If y'all have any specific questions, you can put them in the chat. I want you to at least scan here and just look at SurePass Pro, see if that's something that might be beneficial to you coming up. And I definitely want you to scan here because, again, lots of free things, lots of exciting things coming out for 2025 that you are not going to want to miss here at Archer Review. And if you haven't already taken advantage of your free trial of the QBank or signed up for some more free webinars, that's free stuff, we want you all to go ahead and plan to do that. And I'm going to see y'all real soon. And I think I'm going to open up the chat and just double check, make sure there's no other questions, and then we're going to call it for the day. I'll let y'all get back on with your Monday. I hope y'all have a great rest of the week. Happy New Year again to all of y'all. And if there's anything that we can do to help y'all, you email us for questions. We'll be happy to help you book a mentoring session. You can do just that. So lots of different things that you can do because we want to really meet you where you're at and what your needs are for your learning style and how we can be of assistance to you. So just reach out and we'll be happy to get in touch. So with